start.
This is as good as it's gonna get with the technology that I have and how I can use it at this time. All right, so my name is Kara Archambault. I am one of the fellows here at Trinity, and we are going to talk about cancer rehab today. It is something that I have had an interest in since medical school, and looking back at some of my training, just thinking about all of the experiences that I've had, people I've been able to shadow, and experiences now, having gone through my physical medicine rehab residency program and now doing the hospice and palliative medicine fellowship. Here we are today. So this is something that I hope to share with you all and kind of give everybody an idea of cancer rehab, when to utilize, or just kind of get us thinking about, functional impairments that our patients face with a cancer diagnosis or because of cancer treatment, and that it's not just going through treatment. Sometimes, these effects of treatment or the cancer itself are lifelong. And so we'll talk about survivorship, we'll talk about rehabilitation and palliative, how those things overlap, some of the people on our treatment team, and we will talk about exercise, although physiatry is not just physical. There's a lot more than just exercise prescription, but I did want to talk about it. So here we go. Talked a little bit about objectives. I don't have any disclosures. I'm just fellow. So, all right, survivorship. More people are surviving their cancer diagnosis and living for several years after they have a diagnosis. So we've got better screening, we've got better treatments, more targeted treatments. So what do we do with all this? Now, there's been several national groups. I listed a couple here: American Cancer Society, National Comprehensive Cancer Network. They use the term cancer survivor to refer to patients who've been diagnosed with cancer, regardless of where that patient is at in the course of their disease. They also acknowledge impact of cancer diagnosis and what that can have on family members, friends, and caregivers. Although with a lot of the guidelines, it's directed more towards the patient themselves, but they do acknowledge that cancer doesn't just affect the person, it affects their support network as well. So again, just some numbers here on survivorship and the prevalence here. There's an estimated 18.1 million cancer survivors in the United States as of January 2022. So like I said, with all of these people who have had at least one cancer diagnosis, some of these people who are living beyond this 5-year survival mark will sometimes even have a secondary primary cancer to put it that way. So what now? How do we help these patients as they're living with the aftermath of their diagnosis and what is now new normal?
It's interesting.
Here, we'll go back here.
1975, right? That's like Betty Ford era, and less than 4 million people. And now more than 5 times that.
And again, our kind of awareness,
yes,
and screening and saying this is what this is, the pathology, and being able to see and identify these kind of diagnosis and the support networks that we have. And it's been, like I have at the top here, public health initiatives are a huge part, a driving force for identifying these people and how can we help them.
Yeah.
All right, so this is the National Comprehensive Cancer Network has set guidelines for providing screening, evaluation, and treatment recommendations for many of the physical and psychosocial side effects of cancer and cancer treatment that survivors face. So as you can see here on the right-hand side of the screen, there's a lot of guidelines that we could go through. Cardiac toxicity as a side effect of some of the agents being used in treatment, anxiety, depression, trauma, and distress related to the diagnosis, cardiovascular disease, cognitive function. You hear often from patients who've had chemotherapy of chemo brain and how just exhausting that is. Identifying cancers in younger patients and how do they return to work and their activities of daily living. Fatigue, fertility, hormone-related symptoms, lymphedema. We just had a great lecture from Dr. Naomi Kaplan about a month and a half ago talking about lymphedema. Pain. We've certainly had lots of lectures throughout the year regarding pain symptoms and how to address those. Sexual health, sleep disorders, and then preventative measures. Again, we're looking at survivorship and how do we optimize health overall in this patient population, and then hopefully do some risk management on any further cancers or recurrence. So healthy lifestyle, immunizations, nutrition, weight management, physical activity, and supplement use. All right, so again, how can we help this patient population bridge the gap between illness and wellness? The state of, I have a cancer diagnosis and everything that goes with that, but I still am living my life day to day. We're going to live life in the time that we have. So again, multiple different national societies recommend that patients have access to both palliative care services and cancer rehabilitation. Now, how that's delivered, across the country, different resources that are available. You're not going to have everybody that they list as potentials for part of the team, but if we can get everybody thinking about these things, having palliative-minded rehab physicians or palliative physicians that keep some rehab concepts in the back of their mind, how can we help patients? I think that will help us overall. So there's that overlap area that I think could be really helpful for patients in addressing quality of life. So let's talk about palliative medicine as part of the care team. I don't have to belabor this point because I'm speaking to a lot of palliative people right here. So the definition per the Commission on Cancer is that palliative care refers to patient and family-centered care, optimizing quality of life. The availability of palliative care services is an essential component of cancer care. It begins at the time of diagnosis and should be continuously available throughout treatment, surveillance, and when applicable at end of life and during bereavement for family and loved ones. So types of palliative care services and what we do. Again, I don't have to belabor this point, but we address a lot. It's a team-based care planning approach. It involves the patient and family. That patient is at the center of this. So we need to use our cultural competency. We had another wonderful lecture on that and narrative medicine recently for individualized and shared decision-making. What's important to the patient, in addressing that symptom burden, pain and non-pain symptoms. Facilitating communication among patients and families and provider team members, making sure everybody's on the same page, giving patients a space to be able to ask questions or brainstorm questions that they can bring up to the rest of their oncologic team. Education about illness and prognosis at times. Assistance with medical decision making. We do a lot of advanced care planning and what's your line in the sand? What things would you not want? How do you want to be cared for? Attention to spiritual needs, our pillars of human existence, right? The mind, body, and spirit. How are we looking at our person as a whole person? And then, of course, bereavement support for families and care team members. So what do palliative and rehab, how do those things go together? I think of them as PB&J. It's a classic, right? To me, the way my mind works and the way I've seen things throughout my fledgling career, they go together so well. Palliative, we're looking at quality of life and how can we maximize the things that patients find important. How can we help them do that and manage symptoms so they can do the things that they enjoy and go about their daily life? And that's how I see rehab medicine as well. How do we address the functional impairments that patients might have so they can still do the things that are meaningful to them. And sometimes that's as simple as being able to attend to their own ADLs. Independence is huge for quality of life. So this statement here, I won't read it to you, but it just kind of talks about the focus of these two specialty areas of medicine and how they really go well together. They're synergistic, function and quality of life. So a great quote from our Dame Cicely Saunders: "The work of all the professional team is to enable the dying person to live until they die at their own maximal potential, performing to the limit of their physical and mental capacity with control and independence whenever possible." So again, this is how I see palliative and rehab going together so well, and how we can help facilitate that independence and potential for patients. But wait, is cancer rehab just exercise? Heck no, it's not just exercise, and physiatry is not the same as physical therapy. So rehab is often equated with exercise, or patients will be, I just need to get stronger, but it's so much more than that. And the rehab team can deliver so much more care outside of exercise. We can address lots of different things, including bowel dysfunction, urinary incontinence, sexual dysfunction, lymphedema, pain, fatigue, cognitive deficits,
That sounds like palliative medicine.
decreased endurance, balance and coordination, and a whole lot more. So we'll get into some of this. Again, I'm not going to get into nitty gritty on specific diagnosis, but just to kind of get our feet wet with what can our rehab colleagues do for this patient population. And we're also going to talk about exercise. So rehab medicine is part of the care team. This is another definition for the Commission on Cancer. Rehabilitation care is patient-centered care that optimizes patient functional status and quality of life through preventative, restorative, supportive, and palliative interventions. The availability of rehab care services is an essential component of comprehensive cancer care, beginning at the time of diagnosis, and should be continuously available throughout treatment, surveillance, and when applicable, through end of life. That sounds really familiar
Really
from a
does.
few slides ago, doesn't
Right?
it?
Yeah,
So again, kind of it's verbiage from the same standards from the American College of Surgeons Commission on Cancer. But just again, showing that overlap of palliative care and rehabilitation care. So again, not exhaustive, but a little bit of what kind of services can we get with rehab medicine? Screening and diagnosis of physical dysfunction, impairments, and disabilities, interventions to manage those functional impairments and disabilities, screening, diagnosis, and management of pain and non-pain symptoms of cognitive function, lymphedema management, physical activity recommendations during and after treatment. So yes, we do talk about exercise, as well as vocational rehab. And that's that return to work. So some of the professionals associated with cancer rehab, and you may not have all of these people on your care team depending on what your patient needs. And I'm not going to talk about all of them, but you can see the wheel here. All the people that could be involved in rehab management. Rehabilitation can be delivered in an acute hospital setting with inpatient rehabilitation, in the subacute rehab realm, out in the community, and then outpatient clinics where patients go to an office like physical therapy, occupational therapy, or speech therapy, as well as in-home therapies as well for a certain subset of patients. But overall, the goal is to optimize outcomes and reduce disability in survivors through early identification and treatment of cancer-related physical impairments, functional limitations, and life participation restrictions. So, physiatrist, that would be me. So that's your MD, DO, your doctors who specialize in physical medicine and rehabilitation. Now, training with physiatrists in cancer rehab, there is fellowship available now. There's only 7 across the country. They're all a little bit different in what they have available, but they're getting some of this information and more studies and trying to implement protocols for patients. So there's still a lot of work to be done on bolstering the type of data that we have to direct cancer rehab programs, to develop cancer rehab programs alongside other oncologic programs like palliative care in the oncology office, etc. So there is information out there, and I use the American Academy of Physical Medicine and Rehabilitation. Their PMR Knowledge Now part of their website is a really good kind of jumping off point. If you go underneath medical rehabilitation, there's a whole section on cancer rehab and different selected topics. It's a nice way to kind of, I've got a patient with this. What do they recommend? Or what other reading could I do? That's a nice way to kind of get into some of the literature there. But then, of course, we've got our core therapy team, physical therapists, occupational therapists, and speech language pathologists. So just as in hospice and palliative care, we can't do the work that we do without everyone on the team. The same thing is true for rehab medicine. We need everybody on our team in order to direct our rehab goals. So physical therapy. Their profession is anchored in movement sciences with the aim to enhance, restore, or optimize function of musculoskeletal, neurologic, and cardiorespiratory symptoms or systems. We promote health and wellness through lots of different modalities and interventions. They can do manual therapies. You think like your soft tissue manipulation, massage type manual therapies, electrophysical, like your TENS units, muscle lengthening and strengthening and range of motion, directed therapeutic exercise, balance and coordination training, transfers, getting in and out of a vehicle. That's really important. Stairs, things like that. Physical therapists can also receive additional specialized training. Neuro rehab, our stroke and spinal cord injury specialists, lymphedema specialists, and pelvic floor, just to name a few. So we think of lymphedema for our patients who've had some disruption in their lymph system, whether that be because of cancer tumor burden itself, because of surgical interventions, and then pelvic floor specialists for our urologic and gynecologic cancers. All right, so occupational therapy. Does that have to do with work? Well, yes and no. It's a profession that aims to help patients manage the tasks and activities related to social, productive, and leisure activities or responsibilities that the patient has, like their activities of daily living and instrumental activities of daily living. So let's talk about those just a little bit. ADLs, that's personal care tasks like eating, dressing, bathing, personal hygiene, toileting, continence management, knowing when you need to go to the bathroom, transfers to be able to get there to do that, and the mobility. Your IADLs, that's your instrumental activities of daily living. Those are things like transportation, managing your finances, shopping, like grocery shopping, navigating that, meal prep, housekeeping, managing your medications and appointments. The inability to perform ADLs and IADLs can lead to patient dependence on others or assistive devices needed. Sorry, there's a little pop-up. But it can lead to isolation, unsafe living conditions, and poor quality of life if there are impairments present. So we hear a lot of our patients say, oh, I don't want to go into a home. I've lived in my house all these years and I've been doing it myself. Maybe they do need a little bit of help. Maybe we need to adjust the way that we're doing things and addressing those things with the hope of maintaining their independence and safety for as long as possible. And then also talking about, well, at some point in time, you might need more help than can be delivered at home. And so let's put that on the table. We can shelve it later, but just thinking about those things as well. So again, palliative-minded rehab care. So what about our speech therapists? They do so much. I tend to think of it in two different realms, swallowing function and then speech production and cognition. But they focus on all of those things. They can assess for safe swallow and make recommendations on what is the least restrictive consistency of food and drink that still optimizes safety for the patient and minimizing risk of aspiration. People hate modified diets, but I promise we do it for a reason. But if that is an area of contention or a patient says, hey, this modified diet is not conducive for my quality of life, then we have those conversations about what are our goals for our care as well. But safe swallow is imperative for proper nutrition delivery. So our speech therapists are a wonderful resource for helping us identify patients who may have high risk of aspiration, and moving forward with that. So if we have concerns thinking of like our head and neck cancer patients, whether they've had direct intervention to those processes or just in the area of thinking of some of our radiation fibrosis, they can help address some of those things, like exercises for maneuvers and postures that help protect the airway during swallowing. That's something that they can address. And then as far as communication and the actual production of speech, they can help with exercises for articulation, vocal strength, breath support, work to decrease vocal strain, and if needed, implement and train with augmentative and alternative communication, such as ABC boards or communication flip books, where they have frequently used phrases or pictures that they can point to. So how can we continue to communicate? Not too long ago, I had brought up a case where a patient had a left MCA stroke and so had aphasia from that, but was having difficulty with communication. How could we connect her to different ways, augmentative and alternative communication, in order to state what her needs are? And we see this often in the ALS community. Now, how can we think ahead for how can this patient continue to be a participant in their care, direct their care? Because I'm going off speech therapy a little bit, but how do we maintain control over a very uncontrollable situation sometimes? Our patients are being faced with a massively life-altering diagnosis and navigating that. And so how wonderful it is that we have all these people on our team that can help address all of these concerns. And communication, being able to state what our needs are and direct our care, is a huge part of quality of life. All right, so getting into the team in cancer rehab again. Most cancer survivors experience acute symptoms during their cancer treatment, and we see these patients often in our palliative clinics and in the hospital. But 70% of survivors will also experience persistent or late effects that can include pain, neuropathy, cognitive issues, incontinence, and fatigue. Functional decline is often identified as a primary cause of emotional distress for cancer survivors. So how could we help these patients? There are different rehab approaches for different phases of cancer treatment: rehabilitation, restorative rehab, supportive rehab, and palliative rehab. So here are those 4 different areas of cancer rehab. The prehabilitation kind of happens in that time of diagnosis before we implement treatment. And I'll get into these all a little bit more in subsequent slides. But I really liked this kind of diagram here. Moving into restorative rehab, if we've had a bit of decline with our treatment, how can we work to getting back to our pre-diagnosis level of function? And then supportive rehab, how do we manage the chronic impairments? How do we how do we navigate disease progression? And then also looking at surveillance after treatment and recovery for any of those late effects. And then palliative rehab, again, kind of looking at that disease progression or relapse in advanced stages of cancer and end of life care. So let's get into these a little bit more.
Pause.
Go
Are you
ahead.
gonna
Yep.
talk about end of life care in the next couple slides?
Yep.
Okay.
With the palliative rehab. Mhm.
Okay. You might answer my question before we get there, so.
Okay. But it has to do with insurance coverage. I don't think I have anything explicitly stated on the slide, but we can talk about it for sure. It's very specific reasons and short term. So here's kind of the concept of prehabilitation and preventative care. Dr. Becker, did you have a question?
No, I just love the word.
Oh, okay. Isn't it
It's kind
great?
of like what we're all should be doing right now, right?
Right? Yeah.
Whatever level we're at, hopefully we're elevating
Happy.
rather than just waiting for the bottom.
Yeah.
So this occurs prior to cancer treatment. The aim is to minimize functional decline during treatment, optimize our recovery, build that reserve, especially like endurance. We want to avoid that fatigue, avoid that physical strain. So we encourage regular physical activity to minimize the deconditioning that happens during treatment. So as you can see here, on this graph, which I also loved, we have our diagnosis and our baseline level of function. If we do a bit of prehab, the hope is to kind of increase that reserve. So then we do start treatment and we do have some decline because that's how treatment goes. It's so physically taxing that maybe when we decline, it's to where we were before we started our prehab. So then we're not trying to dig ourselves out of a hole when we do hit that survivorship point with rehabilitation after treatment. So there are some cancer clinic locations, big cancer centers who are trying to get data on prehabilitation protocols. The one that I am thinking of right now, there was presentation at the AAPMR national meeting back in November about prehabilitation for patients with hematologic cancers prior to bone marrow transplant. So I don't have it in my references because I didn't get into, like I said, I didn't want to get into nuts and bolts of specific diagnosis, just wanted to cover kind of general topics, but that is one that I am somewhat familiar with. So, and I believe University of Michigan is doing that as well in Ann Arbor. Side note, they do have a cancer rehabilitation fellowship. So, all right. So let's get into these a little bit.
We're all an hour away from Lansing.
Yes, everything is far. That's everything in
It's central.
right, is a little bit. So getting into the restorative, I touched on that briefly, but the aim is to return patients to their pre-treatment level of physical, psychological, social, and occupational functioning. So that often takes place during cancer treatment phase, and is typically implemented when there's short-term functional impairments that are anticipated, but not long-term impairments. So, for example, post-op range of motion exercises and strengthening and stabilization for patients post mastectomy, or vocational training focused on functional barriers that may exist for patients who are trying to return to work. So supportive cancer rehab aims to maintain current function and adapt to what is the new level of function when restoration is not possible, and to minimize further decline. This is for patients whose impairment is permanent and or expected to progress over time. So the hope is to facilitate accommodations, durable medical equipment recommendations, and training on safe usage of that equipment. How many times have you seen a patient use a cane or walker incorrectly? The times are not zero. But the goal is here, again, to optimize self-care tasks and support independent functioning for these patients. Now, palliative cancer rehabilitation. The goal of conventional rehab is to restore function, But with palliative rehab, the focus is on quality of life, symptom control, and self-care independence. Oftentimes, we're looking to optimize mobility and activity levels, but using positioning strategies to minimize pain, prevent pressure injury, utilize safe transfer techniques, utilize mobility aids and other durable medical equipment. And I don't have it listed here, but it also involves what we call caregiver training. So training of the loved ones who will be helping to care for this patient. So everybody's feeling safe and confident with the kind of techniques that they need to use in order to help care for their loved one with cancer. Dr. Phillips, you had a question.
Yeah, I'm gonna go back, you don't have to back up to that diagram, but I noticed that on that diagram, there's no box or arrow pointing rehabilitation to end of life care.
Oh, directly to it.
Directly
Yeah.
to it.
Do I want to talk about guidelines or not? I don't know if I have time. So I'm sure you can speak to this, having dealt with it with your ALS patients. But if I am thinking of rehabilitation for end of life patients, it's very specific and limited interventions, usually for optimizing home safety and for medical equipment. So again, in my very limited and green experience here, some of our nursing staff do an excellent job in recommending certain durable medical equipment like hospital beds or different types of patient lifts, shower chair, tub bench, things that are going to hopefully make life easier and the energy expenditure on the things that we want to do and not walking all the way across the house to go to the bathroom or up and down stairs. How can we optimize the situation that we're in? So like home safety evaluation with occupational therapy, I think would be something that is reasonable. Is that what you were asking about?
I think along those lines, I mean, I'm seeing a lot of what we see here in palliative rehab. That's something that could be carried on through hospice and through end of life, especially range of motion. I mean, that becomes very big for some patients who are laying in bed. You get stiff, sore muscles. Just working those arms and those legs can be helpful. But positioning, the caregiver teaching, I think too, a lot of this, I would love to see it over into hospice. We run into the payer issue, which is a whole different. But for me, I've just come to realize over the years that rehab is not necessarily all restorative. There should still be a role in hospice and end of life. Now, figuring out how to pay for it.
Yeah.
Let's
maybe in 20 years, like we'll be advocating, continuing to advocate and get somewhere. Yeah.
Go to Lansing.
I do have a slide on immobility and bed rest though, so I'm glad you brought that up. So let's carry on. Here we go. I won't read all of this, but just kind of getting to like what rehabilitative palliative care is. Person-centered. We're focusing on support to best meet people's goals and personal priorities, right? This is interdisciplinary, multi-professional. We can't do this work without everyone on the team or everyone needed for this patient. It's collaborative. It's about optimizing patients' ability to function, about living with dying, or living in the days that we have left with that independence, autonomy, choice, and dignity.
It's ironic. You could almost put multiple specialties up there, including oncology at the bottom there.
Right. These are our goals
about
for
ignoring,
patients.
denying, or pretending it isn't happening. Spoiler alert, I've heard from time to time that may happen.
So, and see this here, rehab palliative care is not just about mobility and walking. It's not just exercise, although it is really important.
It really is about those foundational pieces, which helps people live well and be as whole, Right, I mean, all of this really stems from a person's sense of self and how that is impeded, if not just almost destroyed, and helping them get back to that sense of self. And to a degree, too, we talk a lot about getting back to where we were. And really, a lot of it is getting back to, trying to reclaim
Yes, forging a new self.
and a new normal
Yes.
right
Yep.
there. And being
Got
at
it.
peace with
Yeah.
that. Yeah.
Yep. So again, here's that kind of overlap of palliative and rehabilitative care. I won't read this one for you. It's in my slides, but just definitions of rehab and palliative care and how those things come together. Again, living as fully as possible with choice and autonomy within the limitations of advancing illness. This could be applied to more conditions than just cancer, and we know that. All right, so we will talk about exercise. And I wanted to talk about exercise and fatigue because of that. Through my reading, through multiple textbooks and different articles from different cancer societies, cancer-related fatigue was, as this definition says, a distressing, persistent, subjective sense of physical, emotional, and or cognitive tiredness or exhaustion related to cancer or cancer treatment. Oh, man, just thinking of that and just how everything, even quote, simple activities of daily living, you think to yourself, oh, how am I going to do this? How am I going to get up and do the things that I need to do? And just how exhausting that is to be thinking about that instead of thinking about the things that you want to do. And having to kind of ration out your energy for the day. So how does exercise and fatigue go together? But let's talk about why fatigue occurs. Well, there's lots of different reasons. Disturbances in our sleep cycle, dysregulation in hypothalamic pituitary system, deviations in our central nervous system serotonergic regulation, elevated levels of pro-inflammatory cytokines, anxiety, depression, and history of fatigue prior to cancer, high symptom burden, other psychosocial factors. This is a huge life change. It can be really expensive and lots of doctor's appointments, and it's really scary. And then physical deconditioning. So we'll talk about bed rest here, and immobilization decreases strength by about 1 to 1.5% per day. So think about our patients in the hospital that are just wiped out after an extensive stay. No wonder strength can decrease as much as 20 to 30% during 7 to 10 days of bed rest. This is why mobilization is so important. I would really love to support our inpatient therapy teams so they can do some of this mobilization, support our inpatient nursing teams so they can support movement for patients, and getting them up to the chair at the very least would be so helpful. But there's an estimated 5 to 10% of muscle mass loss per week of bed rest. Thinking of some of our patients who have these prolonged hospital stays or they're on long-term acute care. Here's some other physiologic effects of immobilization in bed rest. The lack of stress and tension on bone via weight bearing leads to osteopenia. Joints have decreased. They have a decrease in connective tissue extensibility, that's a stretch, and articular cartilage begins to deteriorate. Hyaline cartilage and synovial, that it relies on joint mobilization to get that fluid and nutrients moving because they're poorly vascular. And then we also get skin atrophy, and there's risk for pressure injury. A redistribution of bodily fluid when laying supine can lead to postural hypotension. And then we get loss of diaphragmatic and intercostal strength, leading to impaired cough, impaired secretion clearance, decreased ventilation. So I'm sure you've been rounding and seen those incentive spirometers at bedside. Encourage your patients to use those. And then urinary stasis can lead to increased risk for UTI, and decreased GI motility will lead to constipation and lack of appetite. So a lot of physiologic effects from immobilization or bed rest, not moving as much. So even starting with small activities, even at the bed level, can be helpful. You know, sometimes I'll encourage patients to do those ankle pumps, just moving their ankles back and forth, moving the feet back and forth. That can help. Little leg lifts when they're in bed or in the chair, or just like a nice stretch, kind of mobilizing their arms, taking deep breaths, using that incentive spirometer. You're like, all right, we're sitting here in your hospital room, hospital bed. During the commercials, use your incentive spirometer. Do some, stretching, move those legs a little bit. Even little bits can help.
Dr. Dupuy has a comment here too.
Go
He
ahead.
says, at Faith, we have Holland Home PTOT and we have them consult in hospice for safety equipment needs and home exercise.
Yes, yep,
So Faith is ahead of the curve.
perfect. That's exactly how I would want them to be used. It's great. So again, here, exercise and fatigue. Wait, if we're already fatigued, how is trying to do more going to help? I just talked about having this small reserve of energy, and where are we going to use that energy? And are doing therapies and going through intensive therapy the best use of our energy? Well, that depends on your patient. I think it's important to have those conversations. And are they appropriate for an intensive rehab, like inpatient rehab, or can they tolerate subacute rehab? Or do we just need to get moving? Do some walks during the day. Stand up out of the chair. There is a test. And I won't have everybody do it because we're all in rolly chairs. But one of the functional tests, kind of like your get up and go, your time get up and go and 6-minute walk test, is doing 5 unassisted stand-ups from your chair. And how are you doing that? Do you need to kind of use your supports to do that, or can you do those? And just using those big muscle groups can be really helpful. This is something a patient can do all at home, hopefully. And if they can't, how can we do that safely? So it is important to find that balance between rest and activity. But multiple cancer guidelines encourage at least some level of physical activity. A lot of them will recommend some gentle walking, but aerobic activity and resistance exercise can help to improve bone health, cancer-related fatigue, our sleep cycle, anxiety, depression, and our health-related quality of life. So moving just a little bit. I hate to say it's so cliche, but use it or lose it sometimes. Let's keep moving. So this is really wordy, but this is one of the guidelines, the National Comprehensive Cancer Network. They've got a ton of guidelines, like I showed at the beginning of this presentation, but just some of their physical activity and exercise recommendations. Here's another kind of example: light exercise, moderate exercise, and vigorous exercise. There's different like metabolic equivalents for different types of activity, but kind of a general rule of thumb for moderate exercise is that you should still be able to have a conversation while doing that type of exercise, but not be able to sing. So that kind of use of air, singing takes a bit more, so you shouldn't be able to do that. But if you can sing, maybe work a little bit harder. And if you can't carry on a conversation, maybe back off a little bit. So this is a really great brochure, this Moving Through Cancer Guide to Getting and Staying Active During Cancer Treatment. I took some screenshots here of, again, some of the physical benefits of doing exercise. Less cancer-related fatigue, improved bone health, makes everyday activities easier. This is that endurance piece. Now, sometimes we'll hear patients say, I can't even walk to get my mail. Well, then let's start small. Let's go from the bed to the bathroom to the chair, chair to the kitchen, and do that a couple times a day. And then maybe build up. And then I love this. Try adding physical activity snacks throughout your day. Just little things throughout the day. It doesn't have to be a big intense workout all at once, but those little things throughout the day can add up. So here's another quite wordy table, but effects of exercise on health-related outcomes in patients with cancer. So again, cancer-related fatigue, quality of life, physical function, anxiety, depression, lymphedema. So doing aerobic activity only, resistance only, or a combination. And most societies recommend a combination of both. So I did want to talk a little bit about aquatic exercise. I feel like the patients that I've referred to for like in pool therapy love it. But due to the buoyancy, a patient in chest deep water has decreased weight bearing load of about 40% total body weight. So this is great for patients who have a lot of like joint pain. But water viscosity has resistance to movement that is equal to force exerted by the patient. So just moving through the water offers some resistance. So it's both a resistance and aerobic type exercise. And there have been studies reporting improvements in pain, fatigue, physical function, balance, coordination, muscle relaxation, and quality of life after participating in pool-based therapy programs. And in different studies show this having quite a long effect. There was one, I think it was a meta-analysis that showed some of these studies have like 12 months to 24 months of continued effect. That's the end of my, I thought I had one more slide, but maybe I accidentally deleted it when I was cutting out slides. So I apologize for that, but that leaves us some time for questions. Like I've been saying, I think there's a really great overlap with palliative and rehab care. We're both looking to optimize our patients' quality of life and their function. How do we go through our day-to-day life, and how do we face day-to-day life with this new diagnosis? How do we navigate cancer care and survivorship? How do we live with the aftermath of this? Know all those effects that can happen, like the brain fog or fatigue, neuropathy. You know, your physiatrist can also do EMG studies if we have concerns for neuropathy, referring patients for balance and coordination training in the face of neuropathy, things like that. So I will open it up for questions. Thank you, everyone, for bearing with us with the technical difficulties at the beginning, and for listening to me ramble about rehab and palliative medicine, which my two great loves in my career. So thanks, everybody. Those are my dogs.
They're nice. Small ones, are they small?
Say rehab and palliative.
So the smaller one on the left, that's Aquila. His 4th birthday is coming up. And the one on the right, that's Cora. She's our older girl. She's going to be 9 in July. Those are my dogs. Those are my children. Happy Mother's Day to me.
You know, it's really uncanny just as you give this presentation, the overlap. Synergy, maybe is a better word. It's we oftentimes in our lectures talk about, you know, there's that definition of palliative medicine and patient-centered, whole person-centered, living well, you know, serious illness. And, you know, I've always thought of PM&R, as a physical specialty. But probably since watching the Christopher Reeve, there was there is, I think it's called Superman, right? Not Superman, a person, a human who is super, which we all are. And, I mean, this all starts really when he made the decision, right? When he first found out his situation, he kind of opens up that he really wishes I were not here. And when he realized that his family, his wife especially, would still, you know, I love the person you are, he kind of makes this decision. So everything that flows after that flows from that decision. And so it is a physical specialty, but there's so much more when you integrate and think about, getting that person, what do they want and where can we meet them where they're at? And
Yeah, that little kernel of human connection
Yeah.
and helping a patient navigate emotions around that when you're faced with a life-altering diagnosis such as cancer, such as neurologic insults like an ALS diagnosis or a stroke or spinal cord injury.
Mhm.
How do we reframe who am I?
Yeah.
And what is worth it to me? And what are the things that I want to do and find meaningful? And sometimes when I've taken care of patients on the inpatient rehab side of things, it's being able to do those ADLs. You
Yeah.
know, it's celebrating those small victories. I was able to do my own transfer today. I was able to do a shower and they didn't have to help me at the end.
Mhm.
You know, those kind of things I always loved, kind of peeking into the gym and being sneaky and watching my patients, while they're working with therapies and then watching them do a task that has maybe been difficult or it's a new challenge for them because they've been progressing and then being able to cheer them on and celebrate those victories. And then I'm also, managing everything from sleep, their mood,
Mhm.
bowel and bladder,
Mhm.
pain control, optimizing them to be able to participate with those therapies.
Mhm.
My goal is to get them home as quickly and safely as possible.
Yeah. And it's whole.
Mhm.
And think about just the ADLs, right, of toileting oneself.
Yep.
It's something we mostly take for granted. And then when you can't, how the world just may
Mhm.
narrow right down and you help.
Yeah.
Good for you.
Mhm.
Hey, Kara, Steve Dupuy here. I just wanted
Hi,
to say,
Dr.
how are you? Now that
Good.
you're almost done. Look at you guys all graduating.
We
I
made
want you to
it.
know I had no idea what PMR was till I spent 2 months with you, and now I have a serious case of rehab on my brain.
Didn't we have
Um,
so much fun?
oh my gosh, I never looked at the PT assessments before I went into a room, but I did want to ask you a question. The cancer rehab programs, do they still have to qualify for the acute rehab 3 hour a day, or are they more lenient about taking people this debilitated and starting from scratch?
So if we have a patient who has a cancer diagnosis and functional impairments because of that, and they're in the hospital and we're looking for like what is our post-acute care level of rehabilitation that we're recommending. When I come in and I'm doing a consult for that purpose, I am looking at what are their therapy needs. So patients who are going to be referred to inpatient rehab need to have needs that can reasonably be expected to improve with a course of inpatient rehabilitation in at least two of those three disciplines: physical therapy, occupational therapy, and speech therapy. So they have to have at least two of those. And for inpatient rehabilitation, yes, they do need to be able to participate with the 3 hours of therapy a day for at least 5 days a week. They're stay inpatient for the duration of their inpatient rehab stay. So that's 15 hours over a week. With our cancer patients who may be experiencing cancer-related fatigue or high symptom burden, we can do what's called special intensity of inpatient rehabilitation and spread those 15 hours across 7 days instead of 5. So I will also use that designation for some of my patients who are end-stage renal disease and need hemodialysis, or for my post open heart patients with like a lower ejection fraction. Did they answer your question there?
Yeah, you did, and I think she probably will qualify. She's been in the hospital for 2 months from her diagnosis of stage 4 colorectal through radiation and then to perforation of her
Oof.
colon, followed by surgery. And oh my gosh, she's young and debilitated, but I think she has a lot of potential. But the hospital liaison just said, "Oh, she can't do 5 hours a day, or I'm sorry, 3 hours a day." And I said, my gosh, she has so many needs. I mean, it's kind of overwhelming. But we have the luxury of getting Dr. Reisig at Metro doing a
Oh,
PMR.
yeah,
So,
perfect.
yes, he's going to see her. But and also I have a PMR MP who drives me nuts and looks at,
We love Danielle.
oh my gosh, she looks at all this stuff and it's like I'm trying to do medicine, right? And she's making me like look at the whole person, and it's like, oh my God, I have to be a DO again. But anyway, I just wanted to tell you, I really enjoyed working with you. I had no idea how integrated PMR was. And
Right.
we've been so lucky. We do all the acute pain at Metro. And Dr. Isaac has a spinal injection program at the Y on our campus. And he takes these people right to his office after discharge and blocks them and follows them. So very high-end treatment and therapy.
We've got a lot of tools in the toolkit.
Ugh, very much so. Well, thanks for adding a whole dimension to my osteopathic background.
Woohoo, that was the goal, and hopefully this talk today accomplished that for other colleagues on the Zoom.
You did.
Got one more question for you.
Okay.
And that's of speech and language, because I know you talked about swallow, you talked
Yes.
about the speech portion,
Mhm.
you mentioned cognitive a little bit.
Yes.
Can you expand on what an SLP can do for cognitive assessments?
Yeah, and maybe you can speak to that as well. But in patients that I've taken care of in the rehab capacity, when we're looking at cognition, it's attention, what is our memory, short-term, long-term, executive functioning, and specifically with rehab, a lot of the tasks that we're doing are related to ADLs and IADLs. Sometimes sequencing can be incredibly difficult for patients. So imagine trying to manage your medications as a cancer patient and other comorbidities that you might have. It would just brown bag after brown bag of medications to sort through. And how do we arrange those? So sometimes they will do activities with patients as part of their therapy to say, okay, these are your medications. I'll give them kind of like beads in a medication bottle and say, all right, set up your medications for the week. Can they read the label and put those in their pill box appropriately? Can they read the label and say, what is that for? Kind of those kind of sequencing. It's a safety thing. And so both speech and occupational therapy help a lot with the cognitive aspect, thinking through like occupational therapy and fine motor, and doing those fine motor tasks comes down to a lot of sequencing. So they can do different tasks like pick up the ring from this side, switch hands, and then put it on the board. There are lots of different activities. And it was just occupational therapist week not too long ago, maybe about a month ago. So they do a lot of great work. But yes, they can administer the MOCA, and do the cognitive exams for patients as well. Again, kind of looking at attention and concentration, executive function, abstract thinking, again, all with the goal of safety and independence for those patients. Sometimes they'll, all right, balance the checkbook, or, look at the calendar. What appointment do you have coming up? Can they do those things before we send them off into the world to be independent? So I don't know what kind of
I think
experience you've got with your
what I've
patients.
experienced, most people when they hear speech therapy, they think either swallow, because that's what they see in the hospital,
Mhm.
or maybe speech impediments or that sort of thing in the outpatient setting. But this whole cognitive realm is really important and valuable to know about as well. If you've got a patient who you think has some cognitive deficits, we don't have to wait the 4 months to do a 6-hour neuropsychiatric test, but you can send them to speech therapy and get an assessment and
I didn't realize
and get some inputs and some actually treatment and interventions going, which can be very helpful for their day-to-day living.
Yeah, it's absolutely essential for our traumatic brain injury patients, injury patients from metastatic disease. Like we've been saying, chemotherapy brain, what are good cognitive strategies for memory or for remembering appointments and important things. And then also, our stroke patients, think cancer is a hypercoagulable state, so they're at risk for some of those like thrombotic events. And if we're thinking left MCA stroke, then we could have aphasia, some language production impairments, but then even our right MCA stroke with the anosognosia and the lack of awareness of the deficits that you might have and what safety risk that can be for a patient. So working through some of those kind of implementations for best safety for the patient so they can maximize independence if possible.
I have a general question. How well or how much is cancer rehabilitation integrated into palliative now? Like, I mean, is this like kind of a new thing, or has it been done but just hasn't really been described, or the nomenclature just hasn't been there all these years? Or is this kind of like a fledgling field that you're kind of starting to get into?
I think
it's getting more traction.
It's an evolving field. There's a really great big textbook, Cancer Rehabilitation Principles and Practices, that I use quite a bit for this presentation. And like I said, there's several different fellowship programs throughout the United States now. But kind of like hospice and palliative care, people have been doing this work before it was a specialty or before it was, a fellowship trained specialty. And I think, like we've been saying throughout this, the overlap and synergy between palliative and rehabilitative kind of not priorities, but the way that we see the patient and that whole person, how are we optimizing their quality of life? I mean, function is a part of that. So sometimes you'll have a patient who comes into your outpatient clinic associated with the cancer clinic, and they're like, oh man, I've been doing the chemotherapy, but my feet are killing me. I've got the numb and tingles and I feel off balance. I hope our colleagues here are thinking, maybe I could refer that patient to physical therapy and work on some balance training. You know what? That's what I should have done for everybody is do like, how do we do a referral to physical and occupational therapy, different things that you can put in your referral. So when I'm referring, I will often include some specifics, like just like a one-liner. This is a patient who, with this diagnosis, who's coming to me with this complaint, and I would like you to evaluate for, they've got chemo-related neuropathy, and are having difficulty with balance and coordination. They have a flight of stairs they need to get up to. I'd like you to work on balance, strength, coordination, endurance, and appropriate DME recommendations if needed. Please call me if you have any questions. So I will usually include a little bit when I'm doing a referral. Does that help?
Yeah.
Okay, perfect.
Thank you.
Anything